Anyways, today I am talking about why doing bridges is a hoax for rehab. Okay, most of my patients have come from other physical therapists, and when you ask them what they did, inevitably bridges comes up, right? And I am like, you need to stop doing that immediately. And now in the medical system, okay, this is how it goes, right? We go from research, the latest fad in the research, to research, the latest fad to the latest fad to the latest fad, right? But I looked at what I was doing years ago and what they kind of taught me in school type thing, or what I learned on my clinicals or whatever, the fads. And I looked at it and I was like, yeah, no, this doesn't work, And, a good 30% of my patients weren't getting better type thing. And I'm like, that's not acceptable to me. Like, I can't deal with this, So I threw the book out and I said, there's got to be something that people are missing here, right? So I looked at the body basically like a child would, like someone who had never learned anything before, just basically anatomy. And I started testing things and I started checking and trying to understand what was happening. And without preconceived notions of what I had learned in school, what this person says, that person says, right? All the gurus, the mentors, the whatever, right? And I just wanted to know what could possibly be wrong with this patient or this condition, or what causes it and how do I get it better, right? And now, this is not my opinion. This is a historical fact, is that if you are one of these people that jumps from fad to fad to fad in the rehab professions, it is an historical fact that you are going to be wrong most of your career. It is not my opinion. It is a historical fact. So my examples include, quote unquote, and I use quote for therapeutic ultrasound, because that does not work and it's proven not to work, yet everybody still does it. Core stabilization. There was a meta-analysis, proven not to work for back pain. Traction, decompression. There's people that charge thousands and thousands of dollars. My patients come from these places. I spent $7,000 at this place for decompression or whatever. I'm like, yeah, it's actually proven not to work. And the SI joint doesn't move. Remember that, right? People still say that crap. The SI joint doesn't move. Well, I published a paper in 2020 debunking that. So the list goes on and on and on. And if you just keep going, you'll find more things where the orthopedic establishment was wrong. And we see that we all got a master class in this in recent history of, the medical establishment. They dig their heels in and they say, we're right, everybody's wrong, and no one can question us. But then they turn out to be wrong, right? There's no apologies. There's no, oh, I was wrong. It's just like, well, let's just move on. And, it's just how it goes, right? I am not okay with that. I am not okay with being wrong. That is not something that I think about this stuff day and night. If I can't figure something out, I'm obsessive. So I obsess about it until I figure it out. If there's something that is off or something, generally I see the same thing all day all day, the same conditions. So, the ones I've figured out, but I will obsess about this stuff until I figure it out. And it's an involuntary process. I don't actually recommend it having an obsessive mind, because it doesn't make for inner peace, but it makes for somebody like me to make discoveries. So anyways, so when it comes to how the way that I work, okay, so I published the root cause of SI joint dysfunction in 2020. I published root cause right after that of sacral torsion, shear, anterior sacral tilt. I created both. I created diagnostic methods and streamlined the evaluation process and showed you what's wrong with the protocol to prove it. Okay, so and then I did the same thing for plantar fasciitis, and after that for posterior shoulder impingement syndrome, there was a debate. hopefully that settles the debate, the paper I published, right? So with me, it's practical. This is not theoretical. The way that the medical system works is they look at these studies as they come out and they say, well, posture doesn't matter was one of the latest fads to come out, right? Posture doesn't matter, and our research shows it. And I'm like, what are you talking about? 20% of my impingement patients, their shoulder, I just tell them to put their shoulders back and down, and they raise their arm up and they go from pain to no pain. And I'm like, what are you talking about? And a lot of this stuff is in front of our eyes. But if you are a hyperlinear data person, you're going to be fooled your whole career. And that's not my opinion. That is an historical fact. You will be fooled your whole career in doing things that either are useless or hurt the patient. But the way that I work is I develop protocols. Okay, I figured a lot of things out, and I develop protocols that are reproducible. So that's why this is taken off. Is all around the world. It's in over 40 countries now. Is that these are reproducible. You can read my SI joint paper, evaluate a patient the way that I showed you, and get them out of pain immediately. You just confirmed that it was caused by an upslip and or out flare, and then you put them on my SI protocol, and boom, your patient, the people that are doing it all are wild about it because they're like, dude, I'm not worried about SI anymore. All these physical therapists, chiropractors, whatever, they're like, I'm not worried about this anymore. And so therefore you can reproduce it. Now, having said that, today's topic is bridges. Okay. So I don't believe in doing bridges for rehab. Okay. I believe in doing bridges. I do bridges like when I work out. Okay. But I don't have a back injury. Okay. So I do not believe in doing bridges. In fact, that hurts patients. And my clinical reasoning is this, okay? So what are the main things we see all day with back pain? We see spondylolisthesis, right? So they get a crack in a vertebrae, you get an anterior slippage, right? The lower grades, people just deal with it. When they extend back, they feel a pinching or sharp pain in their back. The higher grades need surgery, but you generally don't see those because they have surgery. You can have herniated discs. You can have a central protrusion, the budding, the thecal sac. Those people, the behavior of that is when they go into extreme extension, they feel it over the spinous process. Okay, they will point to you with one finger. Okay, match it up with the MRI. Try this out. Okay, posterior lateral protrusions I have never seen cause back pain. They cause leg pain, they cause buttock pain. I've had that. But when I figured out SI joint, sacral torsion shear, and I figured out how to diagnose that, I was stunned to see that most of my patients, that's where all their chronic low back pain was coming from, is in the referred pain patterns for SI joint, sacral torsion shear, was basically lower thoracic into the foot. And it can cause every symptom that sciatica causes. So once I figured that out, I kept opening up SI joints. And I know people around the world that are doing this are saying the same thing. Like, this is the most common cause of back pain. I just keep opening these SI joints up, boom, their pain's gone instantly. No matter what the ortho said, no matter what the MRI showed. I had a guy right now, he can barely move. And he's got severe herniations in his lumbar spine, but they've done surgery on him. But when I open up his SI joints and rotated his sacrum back, boom, pain's gone. The guy couldn't walk when he was in my office yesterday. Barely walk, couldn't even roll on the table. And at the end of the treatment, I opened up his SI, rotated his sacrum back, boom, he got up, extended back, no pain. Now, he had been told for years that this was because of these arthritis and severe herniations, and had surgery on it and became a pin cushion for injections. And that wasn't even the source of pain. So the other things, you can have arthritis, right? Those people hurt in extension, they compensate by coming into flexion, but they're older. They're usually 60s, 70s plus, some 50s, but usually 60s, 70s. And then you have SI joint, sacral torsion, sacral shear. Those are the main things that we see in an outpatient clinic. Now, how I test that I can tell you definitively that bridges don't do anything. In fact, it can hurt the patient. Is when, in order to diagnose SI joint, what do? Per my paper that I wrote, or my courses, my online courses, per my paper that I wrote on my website, wheltonmethods.com, when you have the person extend back, one thumb translates superiorly, right? And that means that they have an upslip, and then you check for the outflares, because SI is caused by upslip and or outflare, okay? And then they usually have a sacral rotation. You ask them to do a prone press up test, have them relax their glute, and your left thumb usually dips in, and they have SI joint sacral torsion, sacral shear. Now, what did we do to diagnose? We do a prone press up test, right? Or I do it in standing extension. What are you doing with bridges? You are putting them into extension. They hurt in extension almost every time. Some people hurt in flexion. Most SI patients hurt in extension. Bridges is extension. So when I see my patients come in and they show me, like this lady today, she had a exercise list from, here's pictures and everything from the last physical therapist. And I'm like, stop doing that. And I'm like, that hurts it, that hurts your back. And she's like, yeah, it hurt, that kind of thing, and it's like, yeah, well, it's because they were putting you into extension, and it hurts in extension. And the aggravating motion is extension. So therefore, you're giving patients exercises to put them into extension. That is making it worse. You know what I'm saying? So beyond all of this, beyond all of the joint kinematics, right? My protocols work for me if bridges is effective, right? And this is what they would do. They know their percentages. They get 95, 99, whatever it is, percent of their patients better with low back pain, right? And they would do what I did, is I put bridges in and I wait. It usually takes me 5 to 8 weeks. I use electromagnetic fields in this new science I'm working on, but I would wait. I would sit there and I would wait. And I wait for my patient to get better, right? And I would do that for 20 people, right? And then I would take bridges out. So I put it in, I take bridges out, right? And then I would wait. And then I'd watch the success rates, right? And you would see the same success rates. In fact, the ones that you put the bridges in will complain of more pain, okay? And if you are putting your patient in pain, in general, in rehab, with the exception of frozen shoulders, total joint replacements, range of motion with, rotator cuff repair, something like that, you are making it worse. You're shearing their back, right? So you can tell right then and there. This is very practical for me. This is how I have figured this stuff out. Is I have these protocols and I started whittling it down. Do I need this? Do I need this exercise? Is this really that important? And I would take it out of my protocol. I needed that one. Boom, I put it back, right? Patient gets better, right? Over the years, that's what I would do, and I would test these things. So if you are doing bridges with your patients, I, number one, believe you're wasting your time. And number two, you could hurt the patient, and everybody does bridges. I get it. Everybody does bridges, right? But you hurt the patient. Now, just a demonstration, when I assess SI, okay, most common cause, and you'll find out, is that I put both of my thumbs here and I have them arch back, right? And one thumb goes up, but the person will complain of pain in their back, usually an extension, because they are shearing their SI joints and their sacrum's torsioned and they're getting a sacral shear there. Now, if you are gonna put, and most people put the rubber band around the patient's knees, and they have them go into extension like that, you are putting the person in extension. You are doing the exact thing that causes so much shearing back pain in SI patients, okay? Now, furthermore, when it comes to piriformis strengthening, okay? So I show you that most people, when they do bridges, they put the band around the knees and they have them externally rotate. That to me is a waste of time as well, okay? And the reason why I say that is because The only time I ever strengthen the piriformis is with a sacral torsion, okay? Because their sacrum is torsioned, which goes hand in hand with chronic SI. Their sacrum is torsioned and you have to bring it back. You strengthen almost always the right piriformis. If you're gonna say the left piriformis you have to strengthen, always test on a 90-90 to check your thumbs, okay? Read my paper on sacral dysfunctions I wrote on wheltonmethods.com. It's free, read it. And if you were gonna say the left thumb dips in, send me the video, I wanna see it. And that the left piriformis is weaker. But when it comes to piriformis strengthening, okay, the only time I do it is with the right piriformis to bring back a sacral torsion. I see absolutely no clinical point, and I've tested it the way that I show you that I test things, okay? Same to similar results that I do. So if you're gonna say that bilateral strengthening of the piriformis helps your patient, then, or is relevant to rehab of low back pain, then how come when I tested it and I took it out, put it back in, then I saw no change? In other words, it was fluff, right? So that's how I test things. So I don't read research papers, and the reason why is because most of them are wrong. Historically, not my opinion, most of them are wrong. That is a medical historical fact, is that most of the fads that go through this profession and medicine in general are wrong, and they get proven wrong. And then we just move on to something else that gets proven wrong. So that is how I diagnose and I treat, and that is how I know for sure that I'm not doing fluff or injuring my patient by doing an exercise that injures them, is because I know my success rates. And if they for some reason start dropping when I change something, then I know that it was that, it's a variable, right? So that is what I recommend. I recommend, if you want to test this, okay, those that want to do bridges, those that are listening to this and say, hey man, you're full of it, bridges work, right? What I want you to do is to go to wheltonmethods.com, it's free, and download read my SI joint paper and start checking people for SI joint dysfunction, sacral torsion and sacral shear, get my sacral paper, and then start recall, and then wait, do about 20 people. And then I want you to take it out, okay? And what you will find is the same thing that I found, that bridges is a hoax, okay? So in fact, it irritates the person, okay? So I hear it all day long. They give me these bridges and it hurt my back. Well, yeah, because they're shearing your SI joint, So anyways, what I say can be tested. You don't have to take a leap of faith with me, like, oh, well, this Ryan Whelton guy says this. No, don't do that. And you should never do that. That is how you fall for these fads, okay? It's like, well, everybody's doing it, so therefore I have to do it. No. You should question everything, and you certainly should question me, everything that I say, okay? Because what I say can be demonstrated immediately on patients, and you can find out whether I'm right or wrong, right? So do that. Please do that. That's what I want you to do, okay? Is take my SI, sacral torsion shear protocol for low back pain, start assessing, start evaluating patients with that, and then once you start to get a baseline of bridges in with the same protocol, then you will see the same results, or you'll hurt the person, okay? Or take it out, okay? And then after that, you'll see that it was the same results. Then bridges are fluff, and you can test it just like me, and you are not taking my word for it. You are clinically deducing what is happening to your patient, okay? All right. Other than that, I am now on Apple Podcasts. I am on Spotify, where you can watch this full-length video. I am on YouTube. All of it is Whelton Methods. All my handles are Whelton Methods, okay? And I'm on every social media platform, okay? And you can take it easy. Make it easy on yourself, okay? Just cut and paste, okay? Anyways, peace. Love you all.